folks still joining, so we're going to give it a couple of extra minutes before we get started. Just want to let everybody know.
I did just restart the recording too, just so everyone's aware. Ladies and gentlemen, Judy Garish has joined the Zoom meeting today.
All right, folks, I think we have at least a quorum of board members present, so I'm going to get us started. It is now 9:34 a.m. on February 3rd, 2021, and I call to order this meeting of the Maine Emergency Medical Services Board. My name is Joe Kellner, I'm the chair of the board. The meeting is being recorded. Before we go any further, I would like to explain the circumstances under which we are holding this meeting and set up some ground rules for how we will be conducting the business of the meeting. Before I do that, please place yourself on mute if you have that capability. As you all know, earlier this year, the governor proclaimed a state of civil emergency in Maine as a result of the substantial threat posed by the novel coronavirus disease referred to as COVID-19. The governor approved emergency legislation that enacted Public Law 2020, Chapter 617, which, among other things, authorized state agencies to conduct public meetings through telephonic or electronic means during the state of emergency. As authorized by Title I, Section 403A1 of the Maine Revised Statutes, we are conducting this board meeting through video conferencing technology. The board posted notices of this meeting on its website in the legislative calendar. It is the board's sincere hope that all of those interested in the subject matter of today's meeting have received notice of the meeting and how to participate electronically. The mission of Maine EMS is to promote and provide for a comprehensive and effective emergency medical services system to ensure optimum patient care with standards for all providers. All members of this board should strive to promote the core values of excellence, support, collaboration, and integrity. In serving on this board, we commit to serve the respective providers, communities, and residents of the jurisdictions that we represent. I need to ensure that we have a quorum, so I'll be calling roll of the members who are participating remotely. When I call your name, please indicate if you're present. Dr. Zimmerman.
Present.
Dr. Scholl.
Present.
Nate Allen.
Present.
Tim Beals.
Present.
Carolyn is not present. Brad Schickman.
Present.
Joe Conley.
Present.
Heidi? Cody?
Here.
Gotcha. Laura Downing? Laura did indicate she might be late. Amy Drinkwater?
Here.
Judy Garish? Judy, I see you, but you're on mute. I'll mark you present. I am present. Rich Kinnalan? Brent Libby?
Present.
Dr. Martell?
Present.
Julie indicated she wouldn't be able to make it. Dennis Russell?
Present.
Steve Smith?
Present.
And Scott Susie indicated he wouldn't be able to make it. We have 12 voting members present. Quorum is 9. We have a quorum. Before turning to the actual agenda, I'd like to go over some ground rules for this meeting. I've already asked that everyone place themselves on mute when not speaking. Anyone from the public should place themselves on mute unless providing public comment. In order to minimize members talking over each other when you would like to speak, simply state your name and wait until I call on you to speak. If we vote on any issues, I'll conduct a roll call vote as required by law. At this time, if any board member has a question, please state your name and I'll call on you. All right. Next item on the agenda is disclosure of any conflicts of interest. Does anybody have any conflicts with the items on the agenda today other than investigations? Hearing none, I will declare that I have an interest in the life flight waiver request. I'll be presenting the waiver and then we'll be recusing myself and exiting the meeting for the board's discussion of the vote, which Brent Libby will chair. Modifications to the agenda. I have two things that I'm proposing we change and add. Ron Gay, our AAG, has requested to do a presentation to the board, which will take place in executive session to provide us some legal advice on the board's roles and responsibilities. I'm proposing we do that immediately prior to investigations. And the other item is the regional reports that were circulated. I would like the board to take action in accepting or otherwise of the regional reports, and we'll put that under new business. Any other changes or adjustments to the agenda or any disagreement with what I've proposed?
Joe,
Yes.
I'm sorry. I just received a private message about a board member asking if they should excuse themselves from this month's meeting. And I just wanted to, I don't know the answer to that. And so I'm just putting out there for you to know it would, yeah, okay.
Ron?
I'm not privy to necessarily the email that Jason's making reference to. But I am aware that there may be a board member that is technically not reappointed at this point in time. And I'm not sure if that's the same board member. So I thought I would give advice on that matter, because if it is that board member, or if there is a board member that finds themselves in that position, then they can understand at least my legal advice. I think that I won't get into the statutory analysis. There isn't a clear statement in the statute that members serve until they either resign or are replaced. Typically, I see that language in other statutes and other board formation statutes. And because of that, for the sake of being safe, I would suggest that any board member that is in between, like for example, your paperwork's pending, but your term has officially expired, I think a good middle ground would be that those board members could participate, meaning not having to recuse themselves, but abstain during the vote. And the concern that I would have is if there is a very close matter and a person that hasn't been re-upped, if you will, and if they vote and it's a deciding vote, it could provide a potential area of attack for that decision. I think I'd be able to beat it back in court, but rather than even having to take up that fight, hypothetically, I would suggest that a board member that has not been officially reappointed yet, especially if they're board members that have been on the board, that they can share their insights and during discussions. It's completely up to the board, and it's up to the board member, but just abstain during the actual vote. So I'm
Ron,
not sure.
we wouldn't have a quorum. There are so many of us that have not heard back. I count 1, 2,
There's
3,
only 3
4,
people
5, 6,
that are
7, 8.
active board members.
Yeah, I would say then that is a rule of necessity. I would say, so we don't have any adjudicatory hearings that I'm aware of, obviously, because I'm not prepared to do any. I would say then, if you haven't officially heard, you have not resigned and you have not been replaced, there is a hypothetical risk. As a lawyer, I'm always going to want to take the most cautious way, but if it means that this board is not going to be able to function because a number of you are still waiting to hear from the governor's office, then I would suggest that we proceed as other agencies do, which is if you have not resigned or been replaced, to go ahead and participate.
Thank you.
Don't we have language somewhere, Joe, that it is actually that we continue until a replacement is that there is some language somewhere. I just forget exactly where it is.
That's the advice we've had from previous AAGs. I don't know exactly the reference because this comes up all the time because the governor's office takes some time to go through these. And Ron, for context, we would have 4 board members able to serve. The balance of the board would not be able to participate if we followed that guidance.
Yeah, and other agencies, and I discussed this with Sam. I'll give it, other agencies, I've had people serve on for 2 years past their term because they were not replaced. The statute specifically just says appointments are for 3-year terms. Members are appointed by the governor. Now, typically I do see an additional sentence, but I think, especially now that I know that you've received this advice prior, it's not the safest, it's not 100% bulletproof, but I'd say it's 80% likely that there would not be a problem. So in other words, assume unless you've been replaced or told you're not going to be reappointed, or you have not submitted a letter of resignation to the governor, then just proceed.
Thank you very much. Okay, any other modifications to the agenda for today? Hearing none, we'll move on to public comment. Is there any member of the public who wishes to make comment to the board today? Okay, we have 2 sets of minutes to approve. The first one we'll take up is the December 2020 meeting minutes. I believe that was December 2nd. At this point, I would entertain a motion or otherwise.
Dennis, motion.
Motion by Dennis, I assume, to approve the minutes.
Yes.
Okay, is there a second?
Amy, I'll second that.
Second by Amy. Any discussion on the December 2nd minutes? Hearing none, roll call vote. Nate?
Yes.
Tim?
Yes.
Brad?
Yes.
Joe Conley?
Yes.
Heidi?
Yes.
Laura? Amy?
Yes.
Judy?
Yes.
I vote yes. Brent?
Yes.
Dr. Martell?
Yes.
Dennis?
Yes.
Steve?
Yes.
Scott? Excuse me, that's it. Scott's not here. Unanimous of those present. Moving on, minutes of January 6th, which would be the last board meeting. Is there a motion regarding the January 6th meeting minutes? Excuse me, January 2nd meeting minutes.
This is Steve, I will move to approve.
I was right the first time. It was January 6th. Motion by Steve to approve. Is there a second?
Brent, second.
Second by Brent. Any further discussion? Hearing none. Nate,
Yes.
Tim,
Yes.
Brad,
Yes.
Joe Conley,
Yes.
Heidi,
Yes.
Laura, Amy,
Yes.
Judy.
Abstain?
I vote yes. Brent,
Yes.
Dr. Martell,
Yes.
Julie, not present. Dennis,
Abstain.
Steve,
Yes.
and Scott's not present. That is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 in favor and 2 abstentions. Motion carries. Next item on the agenda is Director's Report. Sam.
Good morning, everyone. I don't have a ton to update everyone on today, but I do want to brief out on a couple of things. So with the vaccination efforts, we continue to move steadily down that pathway. We're approaching the 10,000 doses mark administered by EMS clinicians throughout the state of Maine. Huge kudos to the 35 agencies that are actively participating in that process. We are actually in the process of onboarding more agencies at this time. I know 2 or 3 that have submitted applications and that we hope to start onboarding those agencies as well. As far as mass vaccination efforts and the continued efforts for community vaccination, we are working collaboratively with Maine CDC. However, EMS agencies that are participating in this public safety vaccination will not be required or necessarily even expected to participate in mass vaccinations at this time, because that was not the ask when we went to them. We went to them for an ask of public safety. We do know that there are several EMS agencies that are very interested in continuing into community vaccinations, and we will be working collaboratively with the Maine CDC and the Department of Health and Human Services to better evaluate what a collaborative model will look like going forward. Likely some of that will require some additional fiscal support from Maine CDC or DHHS to help offset the costs associated with vaccinations if they get into the mass vaccination realm. So that is something we are working on. Connected to the vaccine will be some new business that I speak to a little bit later regarding a scheduling tool. And I will talk more about that when we get to it in new business. As far as other items, I am actively working on building out a relationship with the University of Maine for an institutional review board process with Maine EMS. So we will have a formal relationship with the University of Maine for IRB, for research projects. And so I'm excited to work on that. It's not going to be next week or the next week by any means, but Dr. Zimmerman and I met with the University of Maine leadership yesterday from the Institute of Medicine at the University of Maine Orono, which is exciting. So just letting you know that that is in the works and we are working on that. We did receive all of the reports, which Chairman Kellner did add to the agenda items. So I will not dig into details there until we get to that as an agenda item. And that is pretty much all I have for a director's report. For overall stuff, for legislative update, LD5 did pass out of the committee unanimously as ought to pass as amended. They did amend the rule to add some provisions regarding miscarriages and abortions as medical information that we were not going to have access to. That was the sponsor, the bill sponsor, Senator Sanborn, actually introduced that amendment based on recommendations from other healthcare workers. That was not in the original language that was passed out of the committee last year, but that was an addition that was made. We don't have any, they did add an emergency clause to that, which would give us authority to begin rulemaking as soon as it's signed by the governor. So there are rulemaking provisions within that chapter. I have directed my team to start working on draft rules for a data section of our rules that will define these types of relationships. So know that we have more rulemaking in progress. And recently our rules were adopted formally and were published on the Secretary of State's website. They went into effect on January 10th. We are in the process of publishing a change document, a formal change document, and circulating that to EMS agencies so they are aware of the changes that have come into effect, as well as changes that will come into effect at a later date. Many of the major changes will not go into effect until at least November of this year. So there is an implementation period for many of them, but some of the smaller changes are immediate. So we will have a change document so people can understand what changed, and they can reference that for their purposes. I will turn it over to my team unless you have any questions to me for me, and I'll pause here for just a moment. Okay, apparently I did an okay job today. Can we start with Jason?
So thanks, Sam. Ellen McFarland is here today as the chair of the Community Paramedicine Committee to give the update for the Community Paramedicine Committee. Ellen?
Good morning. Can you all hear me okay? Good. So our last meeting was the 14th of January. We currently don't have draft minutes for that meeting, but I'm going to go down through our agenda and speak to the items that we discussed during that meeting. Currently, under old business, we have 3 open positions, and I'm hoping that Jason will jump in. He's had an awful lot to do with keeping us sort of on task here. So I welcome him to provide any information that I do not. We have 3 current open positions. We have a hospital-based EMS community paramedicine program. We have an EMS training center, and we also have an at-large community paramedicine provider. I believe they have been posted. If they haven't, they will soon be posted. And we're certainly hoping to fill them so that we can, continue with this committee sort of moving forward, promoting and helping to create a sort of robust community paramedicine program statewide. We also talked at great length about COVID-19, the response by the state, the response by, Maine EMS. We talked about the vaccination efforts, and I am amazed that 10,000 doses have been provided by our partners across the state. I think that's really commendable. Being involved in the community vaccination effort, it is no small task to get 10,000 doses out there. We also, I believe, and again, I'll look to Jason just to formalize this, the CP guidelines either are on their way or have been delivered to the MDPB for their review. And I don't know, Jason, do you have anything you want to add to that?
No, we're going to be sending those guidelines over to MDPB, and one of the things that we also did talk about at the last committee meeting was just bringing a focus of community paramedicine education from the committee to say, here's some available resources to the CP committee at large. So that was it.
Yes, and I would say to that end that this is a great group that might be able to even push some things sort of downhill to this committee to be able to put out there. I think training is always a challenge to get good training out there. So I will be working with Jason to try to at least monthly have some current pertinent training that we can push out. Yeah. So we also talked about, and again, I'm going to look to Jason to just provide any background here, any update. Swabbing, vaccinations, and Ready Check Vaccinate. We just sort of talked about what all those things mean, how they might relate to community paramedicine. We did talk about community paramedicine possibly being a vaccination possibility for our folks that are homebound. I know here on the Mid-Coast, we have a significant population that fit that need, and I'm hoping that, sometime in the future that might be a possibility. Our next meeting is next Thursday, the 11th of February, and we will look forward to any new items on our agenda. So I certainly look to you folks for any ideas or questions if you have any.
Thank you, Ellen. And the QI committee did meet last month, and we just discussed at most the next newsletter that's coming out. Actually, no, we didn't meet last month. It was a bad time to meet. Everybody was vaccinating, so there's really no update on the QI committee other than we are still working on the behavioral health newsletter amidst all of the other things that we have going on. So that's it, Sam. Thank you.
Thank you, Jason. Darren?
Yes, good morning. On behalf of the Data Committee, I would like to report that we'll welcome 6 new members to the committee. It had been a committee of 1. So we have added Jay LaCroix, Darren White, Robert Sharkey, Jason Cooney, Rick Petrie, and Stephen Smith as the ex officio board member. So the most pressing matter that this committee is addressing and putting some effort towards is the RFP for the Maine EMS data system that's shared with the Fire Marshal's office and the wildland firefighting teams. We are planning on holding some Zoom meetings that will be open to clinicians and receive some feedback on what we need to be looking for, and with a goal to get that put together by the end of March. Pretty aggressive timeline for a document of that nature. The next meeting is February 17th at 1500. And the last thing that I will say is I just wanted to take a minute and thank all of you out there that are vaccinating for your efforts and for the diligence that you're undertaking in your documentation. The data that we exchange with the Maine Immunization Project is pretty finicky in the data that it must receive, and it needs to be very precise. And so I just want to thank all of you that are making all that happen. It certainly makes my days go a little bit better. So thank you.
Yeah, I will tell you all that Darren and Jason combined spend about 6 to 7 hours a day working on vaccine stuff. So a special thank you to them for the hard work that they do to make sure vaccines are a success. Mark?
Good morning. The EMSC Advisory Committee met on January 21st. We had good attendance at that meeting and gave an update on current activities of the EMSC performance measures and goals. There was a lot of input and a lot of thoughts, and I appreciate the time that they all gave to it. As reported previously, we did not have any bidders for our RFP that we'd put out there. We've talked with a couple of folks since then about possibly sole sourcing it, but haven't had any movement on that. So Sam and I are continuing to look at some other options and some changes, because again, that money has to be spent by the end of March. So we had some proposals that will continue moving forward. We'll likely have pediatric drug reference cards that we put out. We're currently in the process of developing those internally and with some volunteer help as opposed to through the RFP. And the goal is to print those out and put a reference card of drug dosing and normal pediatric vital signs into the hands of every provider. This would be a laminated card similar to what you might hang off a badge. So that will be going out and working on that soon. And so we're continuing on that process. Otherwise, we continue to provide some input on the development of protocols. I'm sure the esteemed doctors here will speak on that later, but we're offering pediatric insight as best we can. We continue to work with the state perinatal groups on providing equitable access to perinatal and infant care throughout the state, and how we can address both where patients end up, and then that interfacility transport of those patients and how it can be best accomplished. We're also working on some education with some folks from Maine Med on safe sleep. This is a program that a lot of parents are educated on about infants not sleeping in bed with parents and the higher likelihood of death from that. And we're going to provide some education around this to EMS to be able to access if they find a situation where maybe a parent doesn't have access to a crib or they're not financially able to provide that, and what the risks are. So we're working on some education that'll be soon put out. So stay tuned for that. We're also working with some midwives groups in the state. As you may know, the state began licensing midwives in January of 2020 and are currently in the process of updating state statutes and rules around this. And those, I'm sorry, I'm getting feedback. I don't know if that's you or Sam. I think you keep, thanks. So the midwives are providing some education, and the goal of this hopefully is to have EMS better understand what roles midwives can take unseen, and also midwives to understand what roles EMS performs. So it's a bi-directional education program. They're going to provide some education to EMS. We're going to provide some education to midwifery. So good stuff with that. Sam, did you want me to talk about the Stork Awards and website now, or is that something later?
Please, 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 please. So Mark has, as many of you probably know, Mark is basically our webmaster, as other duties as assigned, essentially is our webmaster and manages the Facebook page and does an incredible job at both. And he wanted to share with some information that he has about our website, as well as the Stork Awards, which he manages as well as part of the EMSC program. So yes, please do share that, Mark.
So I took over, I'm sorry, I'll scroll through this quickly. I took over your screen here. So as Sam mentioned, I've been doing the website. It kind of fell into my lap a couple years ago. And we previously utilized a program called Dreamweaver that required us to be basically in a state office anywhere within the state to manage it. There was a lot of challenges with that, reviewing it and the functionality and the education behind that. We decided to get rid of Dreamweaver and go to the state's other option, which is a program called Drupal. And working with Inform Me is the state vendor for architecture and design of websites. We developed the website as you see it currently, although it's gone through some iterations and tweaks over the past year. It began, ironically, March, sorry, scrolling up here for a second, March 19th. Ironically, that was the last day that we were in office. So timing was perfect for us to be able to remotely update, access, and control the website. So that worked out well. Just as to try to give users a perspective of this, I did this data report where looking from March 19th through December of 2020, we had about 119,000 visits. These may be from the same people repeatedly, but there was 119,000 hits, about 413 per day or 17 visits per hour. So quite a decent number of activity in there. And as you can see, by the months, our largest were in April, December, and then March. Those coincided with some release of info that I'll go over in just a second. But you can see that over the, pretty static until we release some major updates that were developed either through you guys or through MDPB and the Maine EMS office. The top busiest days of page views, 3 of the top 5 were within 3 days of each other. These were the release dates of the phase 1 protocol update. March 19th was obviously the beginning of COVID, and some information was released about that. And I'm sorry, March 26th was phase 1. April 8th, 9th, 10th was phase 2 of the protocol release dates. So it was likely people downloading those files. Where do they go on the website? And again, board members, you have all this info. Hopefully you've seen it in your packet. These are the top 10 visited pages within the website. So the /EMS is the home page. After that, most people go to licensing, then to the coronavirus, then education, then MEFers, then education documents, then downloading or then visiting the protocol page, then licensing renewal, then protocol resource page, and then service licensing pages. And those make up almost 60% of all visits to the Maine EMS website. What was downloaded? Number one downloaded file was the protocols. After that, the COVID protocol updates or bulletin updates. And then you can see 4 and 5 are also protocol. Then after that is relicensing. Then we go back to protocols for pandemic. And then we see the rest of it's related to licensing. So primarily the things that people are pulling down are related to protocol, pandemic, and licensing, not surprisingly. Again, we had 76,100 files downloaded within March to December. And then what do people do on our website? Number one activity is going to e-licensing and then looking up training report, then going to MEMZ, going to MEFRS, looking up a license, downloading protocols, downloading COVID updates, and that finishes up pretty much all the activities of the visitors. Google, if you think you're not being tracked, is quite frightening. It tracks a lot of information that I didn't put on this. So we know that most people are coming via Chrome or Safari. You know, so that's more important from the back end of making sure that our website addresses those needs of those web browsers. We can also see that 68% came from desktop, but almost 30% came from a mobile device. So quite a bit of folks that aren't using a traditional desktop and utilizing it. Our website is compliant with mobile, so it does look well. We test every page and the activities to make sure that it reads correctly on mobile and tablet devices. Google actually will tell you all the different types of devices that access it. So again, just interesting when we look at releasing any apps or anything like that of what platforms we might need to utilize to reach folks that are accessing it from a mobile device. And that's pretty much it. Any questions on the website information? Hearing none, I will share that the Maine EMSC also does the Stork Award programs. And I want to share this again. So we gave out 45 awards in 2020 to 10 EMS services that are listed here, 5 EMD centers, and 2 police departments. Now, actually, this has one more department that's involved. North Star should be listed in there. It was an oversight on my part and ended up in the 2021 awards when actually it should have been awarded in 2020. So there'll be one more service listed in this. And we also gave the awards out individually to 6 EMDs, 3 police officers, 13 medics, 10 AMTs, 11 EMTs, 1 ambulance operator, and 1 firefighter. And we'll have 2 more clinicians that'll be added to that list when I update that information to North Star. So apologies to them for not including them in this list. If there are other births that occurred within the time frame of 2020, please let me know, and I'm happy to add those in. There are some issues that occasionally occur where I don't know of a birth. I get a report weekly on those. We are happy to add those in and update them if they're not there. One challenge that we run into oftentimes is around documentation. We search for newborns, we search for things like that. We search by age, but in the moment I have, I would say that I would challenge you as service leaders to address what I would refer to as the pandemic of documentation. I'm happy to copyright that name, but we run into the challenge where we'll have a newborn and the chief complaint will be listed as child, no findings or complaints. And that will be the only documented issue that they have. We'll also find mom and infant are written on the same PCR. So we might have patient age of 30 years old, but it actually applies to mom and the infant. So trying to address those and making sure we get vital signs and proper information around those making sure infant and mom have separate run reports, making sure that we document that they're a newborn and pertinent information that way. I think that that's something that is not surprising to any of you, but it certainly remains a concern with documentation. So please remind providers and anyone that's listening to take a look at those and take the time to document things well. It'll protect you in the end. And unless anyone has any questions, that's my info.
Thank you so much, Mark. Chris?
Good morning, everybody. Thank you very much. I believe Brian Chamberlain has signed on. If he would like to give a report for the Education Committee.
Morning, Brian Chamberlain, Education Chair. The only report I really have this morning is we're just continuing our work on the training center document. We had to cancel our meeting last week due to some important stakeholders that were unable to attend, and also vaccination clinics that required personnel. So we'll be meeting next Wednesday to continue our work on that. And we'll also be hopefully finishing up our AVOC discussion next week with regards to that program, and hopefully reporting that back to you in the coming months, hopefully next month, but maybe a month later, depending on how we wake out on that. Other than that, that's about where we're at with our work projects.
Thank you, Brian. One additional thing to add to that regarding protocol update work. It continues with the MDPB as they progress through their changes. There is some concern within the committee regarding the educational lift for some of the scope of practice expansion changes which have been covered by the MDPB, which will need to be addressed by the Education Committee as the change sheets become available and the co-authors are working with each other to develop it. The exam committee is currently continuing work on reviewing options for the psychomotor skills exams. Work is in process or progress for developing a plan to strengthen the pool of PSE administrators as well. Regarding MDPB, Dr. Scholl is present, I believe, and will have his report for you. MEMS Ed, the vaccination training continues, the Ready, Check, and Vaccinate course, which is the skills course that was provided for EMTs to provide them intramuscular training, injection training, was updated to accommodate the replacement of one of the course video resources, which suddenly became unavailable. We've been getting some feedback on both courses, and we've been responsive to any feedback that we've been getting regarding course updates, future courses. At this time, we are anticipating the possible addition of a new course to the vaccination training centering on the Pfizer vaccine. However, as Sam has discussed, that is going to be dependent upon the course of public vaccination efforts and the level of EMS clinician involvement of them. In addition, I've also been attending the EMS Labor Force Committee meetings, though not as the office liaison, but more as a resource for the group. That's all I have to report, unless anybody has any questions for me.
Thank you, Chris.
Thank you very much.
Did you, okay, nothing additional for exam?
Nothing at this time.
Okay, okay. Dr. Zimmerman, do you want to talk about the TAC?
Sure. So we met at the end of January, and the majority of our TAC meeting was spent reviewing a case from Central Maine Med and having some robust discussion about tourniquets. We also continue to work on our bylaws and expect to vote on those at our next meeting in April, and continue to work with our trauma plan. So I have a meeting scheduled later this month for the subcommittee working on our state trauma plan to further develop that so that it is able to be presented and hopefully voted on in April itself.
And I'm sorry to spring this one on you too, but Maine EMS is also taking on the program management side of the Maine Stroke Alliance. And so that has now come underneath our umbrella based on funding that has been given to us by the Office of Rural Health over at Maine CDC. And Dr. Zimmerman, if you want to give a quick snapshot of what's going on there. I know that we have a meeting with them to kind of discuss transition for us, but if you want to give a quick snapshot, because I know you've been actively involved lately.
Sure. So we've been meeting kind of quarterly and have broken into some group committees looking at the spectrum of stroke care from the preventative stage all the way through rehabilitation. I sit on the subcommittee for pre-hospital and emergency department care, as does Matt. And we've been working with several of the hospitals throughout the state that sit on this committee. We have nice representation along with well-versed neurologists in stroke care, and have been working on I think it's very similar to TAC support of the smaller hospitals and their ability to adequately diagnose stroke, provide lytics when indicated, and then facilitate interfacility transfer. And so I know that there are some interfacility transfer documents that are being vetted, and also some sample order sets that make that easier for the sending hospitals. So I think we're heading into the time-sensitive illness realm here with those two committees, and whether we think about cardiology and STEMIs, and then we start thinking about sepsis. You know, I see that as a direction where Maine EMS is headed.
You read my mind, Dr. Zimmerman. You read my mind. Okay. So I will turn it over to Melissa for EMD.
Good morning. The EMD committee also met in January. We have a quarterly meeting schedule. And in this meeting, we discussed goals for this coming year and an annual report proposal that is not completed. We are trying to standardize that in the office. So just a draft of that with some numbers that we went over as a committee. But as far as the goals that were identified, we created some subgroups within the committee to address those, and they include review of the emergency medical dispatch priority reference system, which is a document referred to in the rules that guides many of the operational things that we do, including quality assurance. And we're looking at an addition of focused quality assurance reviews in that guide to bring us into compliance with national standards and with the recently adopted rules from the ESCB, which oversees the fire protocols for the state. Additionally, we are looking to update some of the educational materials that Drexel White had put together for implementation of response plans based on EMD codes. A lot of that material is still relevant. We just need to update some of the slides and make that deliverable so we can get back on some education and encouraging the development of those response plans. And finally, we've had a couple of things come up over the year where folks may be doing things differently across the state, including the dispatch or not dispatch of units to what is considered an obvious death. And we have rules for what an obvious death looks like or sounds like based on a call taker perspective, but we don't have any standard for who goes to those calls. And some people are dispatching EMS and some people aren't. Within the priority reference system document, it does say that it's left to local decision making, but we've run into some incidents where people, EMS has not been dispatched to these calls and then later called because it wasn't as obvious as the caller made it out to be. So we're looking to standardize some of that. And the other item for standardized procedures that we're looking at is calls from ski patrol. And this came up recently that across the state, these may be handled differently from protocol selection to dispatch. And while we have no intention of controlling local dispatch for those, we would like to standardize the way that those calls are handled in the dispatch center. So we have a subgroup working on those things.
Thank you, Melissa. Dr. Scholl.
Are you ready for the MDPB report, Sam? Is that what you're?
Yes, sir.
Well, good to see everybody, and thank you for allowing us to speak. Kate, as always, please jump in if anything strikes you. The MDPB has met 4 times since the last board meeting. Those include 2 meetings specific to our coronavirus efforts, as well as a regularly scheduled meeting and another meeting in addition to that to discuss our protocols. That's been the big item the last few meetings for the group. We are coming around the bend in our protocol review, most recently working on the green section, which holds 3 major updates, including a pretty big update on the head injury section, a big update on the pain management section, and then a new protocol proposing the use of antibiotics in open fractures. As Kate mentioned, this was part of our discussion with the TAC group on their meeting in January. And the group offered to collaborate with us on some white papers, especially around the major changes to the head injury section, because that's, I anticipate, going to be one of the bigger philosophic changes that we see in the green section, at least. We still have some work to do on our pain management and open fracture protocols. We'll be coming back to those next month, along with the pink section, the pediatric section, which is currently under review, followed by the orange section. And then there have been some proposals to include other sort of appendices sections, including one that Kate's working on. I think I've mentioned this in the past, the idea of proposing protocols for the management of injuries or illnesses to working dogs based on legislation that passed in 2018, exclusive for services that are working with, have relationships with organizations that host working dogs. So more to come on that as we get further. There, as Chris mentioned, there are what might on the surface seem to be very subtle changes in this protocol rollout that you'll notice, but some of those are going to be logistically challenging because they're fundamental changes to scope of practice. The MDPB has been attentive to the 2018 national scope of practice changes, which does certain things like moving CPAP to the EMT scope of practice and placing parenteral analgesia at the AEMT scope of practice. And while those are things that our system has done for many, many years, those are things that the proposed scopes of practices have not done in the past. And so those, while again seemingly small, are going to be substantive educational efforts. And we're thoughtful about those and how all the other changes kind of interplay into the education and the rollout of those protocols. And that's a conversation that remains ongoing. The group has started to discuss the supportive material here, including white papers, change references. Some of that work has already continued. Other parts of that work need to begin, but we're working on that too, and aiming again to have all of that information provided and ready for visibility and use in the springtime. So end of Q2 this year, or middle Q2 this year is what we're planning. Any questions about that work right now before I transition to our coronavirus work at all? All right, hearing none.
Matt?
Brent, was that a question someone had?
Yeah, Matt, it's Brent.
Hey, Brent.
On the
can you refresh my memory on when the actual rollout would be? And has there been any thought on the amount of education and the potential of still not meeting as in classrooms?
Yeah, thanks for that, Brent. So the proposed rollout is at this point in time, December 1st. We're starting to look at the summary of all the changes right now to kind of gauge or consider what that looks like and how the sum of all of these changes add up. As far as the delivery vehicle, i.e. not being able to do this in person or not, that's sort of a moving target for us at this moment. Many of the national experts around the pandemic right now are expecting that we'll start being able to gather in the Q3 timeframe, which would potentially support in-person gatherings to discuss this. Although, again, as I'll talk about in a second, there remains so many opaque elements to this pandemic that I think we have to be prepared to, we have to have a couple different delivery vehicles prepared, including remote and video-based vehicles for this as well. So, and then, how the pandemic has undoubtedly affected the MDPB's workload. I know that it's affected a lot of other committee workloads. We've been vocal about being open to that and acknowledging that and getting, making sure that we get the right information out and adhere to that philosophy rather than a strict timeline. But again, we're kind of at the, like I said earlier, rounding the final turn of this protocol review, and a lot of those discussions are ongoing right now, Brent.
Thank you.
Yeah. Regarding our kind of work around the pandemic, we've done a number of things. We're kind of watching very closely the metrics right now. And, I think there's been some discussion nationally about where we're at. What we've been noticing is that we hit greater than 100 average cases per day per week. So more than 100 cases per day averaged over the course of a week for the first time in November. We hit greater than 200 average cases per day each week in December, and then we crested the 500 mark for the same metric in the end of December, beginning of January. The last couple of weeks have been lower. We've been in the 400, then the 300 range. So average number of cases per day, averaged over a week, has been mid to high threes last week, low fours the week before, but in the before that, greater than 500. We're watching these numbers really closely, and in particular, I think the biggest vulnerability that exists for us in the short term is the spread of these new variants and the ability to detect these new variants and what these new variant coronavirus strains mean for us as far as transmission and disease. It's too early to really understand if what we're seeing as far as these average cases per week is a downtrend or not, but we're watching this really closely because this, I think, again, is our largest vulnerability in the near future. Related to that, the number of deaths crept above 1 to 2 per day on average per week for the first time. In November, we got above 2 deaths average per day over any given week. And then in December, we were in the 4 to 5 per day averaged each week. And in January, we hit the 10, 11, and then down to 5, 6 numbers. So again, we're watching that as well. Hospitalizations appear to be downtrending right now, but again, we're concerned about the variants and what that looks like. It's great to hear nationally that the vaccines appear to have efficacy against variants, and so there appears to be a kind of race between getting our vaccination campaigns fully mobilized and vaccinating as much of the US population as we possibly can, while there appears in the early evidence to be some diminution in the ability for the vaccines to reduce disease in the variant strains. That disease appears to be less severe, leading to fewer hospitalizations or severe cases in the early evidence that we have available. But again, we're watching that data set pretty closely as well. And I think for the time being, maintaining our efforts to vaccinate as much of the US population as possible is our biggest goal and strategy. Any other questions regarding that work?
Well, great. Thank you all very much. We appreciate the ability to see you guys and look forward to touching base in the near future. Thanks for all everyone is doing regarding this too.
Thanks, Dr. Scholl, and thanks to all the other staff members and committee members that gave reports prior as well. Very informative, a lot of great work going on. So this is always great. All right, moving on to the next agenda item is legal advice from our AAG, who's requested to provide some guidance to the board based on some legal advice that was provided to the investigations committee last week. And we had suggested that Ron give an abbreviated and focused version to the board today. The legal advice we receive will be done under the protection of executive session. And to that end, I would seek a motion from the board to enter executive session to receive this advice.
Joe, it's Tim.
Tim?
I would make a motion, we enter executive session pursuant to 1 MRS Section 405, paragraph E, to receive legal advice.
Second. By Tim and a second by Dennis. Any further discussion? Hearing none, roll call vote. Nate?
Yes.
Tim?
Yes.
Brad?
Yes.
Joe Conley?
Yes.
Heidi?
Yes.
Laura?
Yes.
Amy?
Yes.
Judy?
Yes.
I vote yes. Brent?
Yes.
Dr. Martell?
Yes.
Dennis?
Yes.
Steve?
Yes.
Unanimous of those that are present. So I will ask the meeting host to place everybody else in the waiting room. For those that are in the waiting room, we'll automatically add you back in when the executive session concludes. I'm thinking probably about 15 minutes. Jason, it looks like Nate Allen was placed in the waiting room erroneously.
Okay, I'll get him out.
I'm trying really hard not to touch it. So.
Thank you.
You're welcome.
I appreciate that.
I knew you would. Ron, I assume it's okay to have staff stay with us for the portion. Great.
So are we all set at this point or?
Not yet.
Not quite yet.
Jason, I see Debbie Morgan still here. I think she's the last one.
Okay. There we go.
Okay. Yeah, I think we're good.
We're all set?
Stop the recording, please, Jason.
Joe, this is Joe. I've got to bail out at around 12:15 today, just to give you a heads up.
I, being the eternal optimist, think we'll be done by then, but we'll see.
Awesome. Second round of COVID shots today for 40 people, so it's going to be a busy afternoon.
Prepare to have some hit the deck tomorrow, if there
Yes.
me.
The sad thing is all but one of my trucks, or all but one truck is scheduled for shots today, so tomorrow is going to be ugly.
All right, I think that brings everybody back into the waiting room, or from the waiting room back into the meeting. Thanks so much to everybody for your patience. The recording has restarted and we will resume the business of the meeting. Next item on the agenda is the Investigations Committee report. We will start with the investigations minutes that were circulated, and this is a vote just of the Investigations Committee members. At this point, I would take a motion to accept those minutes or otherwise.
This is Joe. I'll make that motion.
Motion by Joe. Is there a second? Second by
Judy,
Tim.
I'll second it.
I got Tim with a second on that one. All right, roll call vote. Tim,
Yes.
Joe,
Yes.
Laura,
Yes.
Amy,
Yes.
Judy,
Yes.
and I vote yes. It's unanimous. All right, Melissa's with us and has all three cases this time, so we'll start with 20-152.
Thank you. All right, case 20-152 to summarize. This was received by a regional medical director who reported concerns about a provider's patient care and decision-making capacity, specifically noting a decline in memory and critical thinking on calls over the past 2 years. This was received in October of 2020. He did note that there had been no patient harm during that time. At the time of the complaint, the provider's paramedic license had expired. The service level medical director had recommended a geriatric assessment, which was sought, and concluded that there were no signs of neurological decline, but the physician did encourage a grief counseling and a change in medications. The provider has followed the guidance of her physicians and her counselor over the past 6 months and recently submitted a new licensing application. The service director and the service medical director have worked together to plan a phased return to work for the provider. With all of this information, the committee made a motion to dismiss the complaint and issue the license.
Any questions for Melissa? Concerning case 20-152, we'd seek a motion from the board to accept the committee's recommendation or otherwise. Anybody?
Joe's Tim.
Tim,
Make a motion that we accept the committee's recommendation on the case. I don't have the number in front of me, sorry.
20-152, is there a second?
Thank you.
Yep.
Brent, I'll second.
Second by Brent. Any further discussion?
I have a question, Brent.
Yeah, by all means, Brent. Go ahead.
By dismissing completely, I don't think we see dismissals very often, but that would then essentially, that eliminates the complaint, it eliminates the record of it, and there's nothing left on file. Is that accurate?
Ron, can I defer to you to answer this one?
So by dismissing the complaint, everything remains on the record to the extent, so the fact that there was a complaint, if you will, that remains the subject. So it's still on the record. However, oh, I don't have my, sorry, not that you need my video, but yeah. So during an investigation, all the investigative records are confidential. They lose, the investigative records become public. They're no longer confidential upon a dismissal, the issuance of a notice of hearing, or once someone signs a consent agreement. So to answer your question, these records will no longer be confidential except to the extent they contain HIPAA confidential information. So a different section of the statute will cover all of that. That's under essentially HIPAA. So the case does not go away. It's in our records forever.
Thank you.
Any further discussion on the motion? Hearing none. Tim, or excuse me, Nate.
Yes.
Tim,
Yes.
Brad,
Yes.
Joe Conley,
Yes.
Heidi,
Yes.
Laura,
Yes.
Amy,
Yes.
Judy.
Yes.
I vote yes. Brent,
Yes.
Dr. Martell,
Yes.
Dennis,
Yes.
and Steve.
So I want to vote yes, but I want to notice that I saw Kate's hand start to go up and I didn't know. No? Okay. All right. And yes.
Apologies, Kate, if I missed you. Was there something you wanted to add?
My question was regarding HIPAA. So that would be obviously HIPAA for any medical records of patients that may have been treated, but I'm also assuming HIPAA for that person's own medical interventions.
Yeah. But there's, to the extent, yeah. So the records themselves become confidential in terms of FOA. They're not confidential as to the board staff, though. I just want to be clear because I'm not sure what the concern is, but the record isn't expunged. So to the extent, I'm not suggesting this will happen, but that this licensee were to have a recurrence, then we can make reference back to the any of the prior medical records in a subsequent investigation and the conduct. But to answer your question, yes, both the licensees and the patient's records would be protected under HIPAA.
Thank you, Ron. And thanks, Kate, for the question. Sorry to have missed you. We'll move on to case 20-156.
Thank you. In this case, we received a renewal application from a provider with a disclosure of a criminal conviction. The conviction itself does not meet criteria for consideration. It's a Class C misdemeanor not related to the profession. But the applicant was actively licensed by Maine EMS at the time of the conviction and failed to report it within the 10-day period by statute. So after review of this case, the committee recommends resolving this case by issuing the renewal with a letter of guidance, citing the importance of adhering to statutory reporting requirements to be kept on file for 4 years.
Any questions for Melissa? Is there a motion concerning case 20-156?
Make a motion, we approve 20156 as submitted by the committee.
Motion by Brent, is there a second?
Second.
Second by Dennis. Any further discussion? Roll call vote. Nate?
Yes.
Tim?
Yes.
Brad?
Yes.
Brad? Okay. Joe
Yes.
Conley?
Yes.
Heidi?
Yep.
Laura?
Yes.
Amy?
Yes.
Judy?
Yes.
I vote yes. Brent?
Yes.
Dr. Martell?
Yes.
Dennis?
Yes.
Steve?
Yes.
On to case 20-154.
This is a case of an EMD center whose license expired on November 30th of 2020. And we did not receive a renewal application until December 4th of 2020. That application was processed immediately. During the period of the lapse in licensure, they did process 32 emergency medical calls for service. And the committee recommends resolving this case by issuing a consent agreement with a warning for unlicensed practice. Mitigating circumstances include a high quality assurance program. Aggravating circumstances include delayed responsiveness leading up to the renewal, indicating a perceived lack of responsibility to comply with Maine EMS rules, particularly regarding maintenance of an active EMD center license.
Thank you. Any questions? Hearing none, is there a motion concerning case 20-154?
Brent, I'll make a motion, we approve 20154 as submitted by the committee.
Motion by Brent, is there a second?
Second.
Second by Dennis. Any further discussion? Nate?
Yes.
Tim?
Yes.
Brad?
Yes.
Conley?
Yes.
Heidi?
Yes.
Laura?
Yes.
Amy?
Yes.
Judy?
Yes.
I vote yes. Brent?
Yes.
Dr. Martell?
Yes.
Dennis?
Yes.
And Steve.
Yes.
Unanimous of those that are present. Great. Anything else for investigations, Melissa?
No, sir. Thank you.
I would just add that is a discussion follow-up point to 20-156. We did discuss potentially adding another category to the matrices that allows staff to handle certain complaints, and staff will report out on that at the next investigations committee meeting, I assume. So that did come up as a point of our discussion as well. We'll move on to the next agenda item, which is a Life Flight of Maine waiver request. At this point, I will relinquish my position as chair temporarily and hand it over to Brent Libby. I will participate presenting the waiver as a public member, and then for any board deliberation, I will exit the meeting. So Brent, the floor is yours.
Joe, did you want to do the old business before you go to new business?
Yeah, I probably do. That's what I get for working off of two different things. Sorry about that, and thanks, Sam.
I'll give it back.
Brief on the. Oh, you can mentally prepare yourself some more, Brent. Sorry. On to old business. Thanks, Sam. LD 2105 final report. I chaired this committee, and we did finalize the recommendations to the legislature last week. It was a robust committee represented by EMS stakeholders and representatives of insurance carriers and lobbying groups. We ultimately came to a recommendation that we felt was fair, and this recommendation will go to the committee with oversight over insurance, and I can never remember the full name of the committee. They have the option to report out a bill. Right now, as a reminder to folks, ambulance services that bill commercial carriers out of network are entitled to 100% of their charges. It was a stopgap to stop balance billing or surprise billing of patients in the instances that they're transported by an out-of-network provider for emergency services. And the statute or the law that was passed at that point requested a committee be formed to make recommendations so that this committee might report out on bill to deal with this after the paying 100% of charges expires in October of this year. There were several recommendations. I believe there were 9 total recommendations in that report that I would encourage people to take a look at. One of the key ones obviously has to do with payment. The final recommendation was that essentially insurance carriers are required to pay 200% of Medicare, plus also recognize a rural and super rural add-ons that Medicare recognizes, which are 3% and 22.5% respectively, which hopefully adds some support to the more rural communities that don't have the volume. There was another point that's important, I think, to bring up here that was discussed in committee, having to do with system efficiency and new ambulance services and the process by which those new services are licensed to ensure that the system does remain efficient. There was discussion about certificates of need. There was discussion about community self-determination. The 4-letter acronym escapes me as well, but different options that the board might consider. So these are all points that might come out in the bill that the committee puts forth. But I do encourage folks to take a look at the final report, which was circulated in the meeting materials, and Mark also put a link to it for those that don't get the board meeting materials. For those that are interested in reading the document, it is public. Any questions on LD 2105? Very good. Staffing, retention, and workforce committee updates. I'll hand it over to Steve for an update from that committee.
Thank you, Joe. We had a good hour-and-a-half long meeting last month, actually 2 weeks ago. We have another one scheduled for this Friday. The agenda should have just come out, or at least it will come out once I approve it. There's a lot of good discussion. There's a good group of people. One of the points of discussion was talking about diversity in the group, and we're still trying to figure out how to get more people involved in that. But one of the things that also came off from that discussion was talking about, instead of necessarily starting off with a general survey to the public, let's look at stakeholder groups to decide what kind of questions we need to ask in our survey to the public, or EMS. And when I say public, I mean EMS public. So that was a majority of our discussion, talking about who the stakeholders were. We discussed a couple different subgroups, and we were all supposed to can meet on it and finalize that in 2 days. We're looking at students or up to less than 1 to 2 years in EMS. Then looking at a group that's been in EMS for a short time, a little bit longer of a time, and then looking at service chiefs and sort of trying to get an idea of what kind of questions we need to be asking and what to look for. So it was an hour and a half meeting, summarized short, but there was a lot of discussion on this stakeholder thing, which we did decide to move forward with. So Friday we'll be discussing some more about that, finalizing some pieces. Again, we're looking for anybody that wants to join in and chime in with public comment or whatever. We're a pretty open group at this point, just trying to get some good ideas of how to keep people involved in EMS, how to get people involved in EMS, and where we're going to go in the future with EMS, what kind of things we have to look forward to. So it's a brief report, but that's more or less what we're up to right now. Still in the very beginning stages, and we will continue forward, marching forward.
Thank you very much, Steve. Any questions for Steve? All right, hearing none, that concludes old business. So think of everything I just said about 5 minutes ago, and I'll turn it over to Brent for new business.
Okay, next item is a waiver request of the rules from Lifelight of Maine. And Joe, if you want to present the topic, and you should have had a memo attached from Tom Judge also outlining their ask.
Thanks, Brent. So I will try and be quite brief here. Lifelight is the one remaining service in the state that is not using the image trend solution for patient care reporting. They use EMS charts, which was recently bought by Zoll. They use it because of the integrations they have and because of the data collection tools related to critical care transport. There have been some issues with getting the data mapped over to formerly MEMSR and now MEFRS. At this point, Lifelight is able to map all the data through an upload for all the NEMSIS required elements, but there are a handful, I believe it's 84 state elements that are still needing to be built and mapped, which require custom programming by Lifelight's vendor and subsequent mapping by image trend. We historically have had several importing services, but again, Lifelight ends up being the last remaining. This came up recently as Lifelight is applying for a ground license in addition to their air license. About 1/3 of the calls that Lifelight does at this point in time are done by ground, and Lifelight is seeking to achieve reimbursement for those. Right now, there's no reimbursement that Lifelight's able to collect based on going by ground. One of the pieces that is delaying the issuance of the license is the ability to comply fully with Chapter 3, Section 9, which cites the requirement to submit a Maine EMS patient care report. So again, Lifelight is submitting all the NEMSIS required data, but there are some custom data elements they're not able to map at this point, but are in the process of working in good faith with the state and with the vendor. The request from Lifelight is a 3-month waiver to allow the ground license to be issued to move forward with the work that needs to be done there. Lifelight will continue to submit every patient care report timely with the NEMSIS required elements, but a 3-month waiver to allow time to continue to map those elements both on the ground and the air side while Lifelight is allowed to operate under what we hope will be a new ground license. That's the ask. Any questions?
Joe, there likely will need to be an addition here for Chapter 5, where it requires that the individual clinician submit a report, and it has the same language about the standard EMS report. So we likely will need to include that Chapter 5 language as well.
Okay. There being no other questions, I'll step away for the vote for optics reasons. And
hey, Joe.
It's time. Yeah, Brad.
A quick question: with the reimbursement aspect of this going to Lifelight of Maine, will it negatively impact those services right now that are lending a hand in doing the transports for the Lifelight staff, say United Ambulance or say Northeast Mobile Health?
No, what we're working to do is come up with an arrangement. Lifelight has agreements with carriers where they'll be entitled to a higher level of reimbursement for critical care services. Lifelight would guarantee payment to the ground services that are transporting the life flight crew, and life flight would bill for the critical care services provided. So it actually should be an enhancement in that those services won't need to chase the payments themselves. It'll be a contract payment from life flight.
Hey, Joe, this is
Excellent.
Joe.
Thanks, Joe.
Quick question. So doesn't the transporting agency need the bill?
No, the licensed agency needs to bill providing the care. And the way it's been done to date, and it's allowed by CMS, is that the transporting agency is able to bill for services provided by contracted staff when they board their vehicle and provide the care. But the essentially the way it's going to work, to answer more directly and hopefully more articulately, is that life flight will be leasing under contract for a period of time with what's called a wet lease, the ambulance from the ground provider as well as the driver. So life flight becomes, from the eyes of the payer, the operator. And this is the advice we've received from CMS and from our consultant on the way to do this appropriately and legally. So we would pay XYZ ambulance a fee, and that fee would be to lease the driver in the ambulance. Life flight would bill, collect what they can from the insurers, but the ground transporting agency for that lease would be what they would be getting paid for under contract agreement.
So so the transporting agency ends up billing life flight as part of that lease.
Yep.
Okay. So I guess, again, not to throw a monkey wrench in it, they're just trying to get, so if they're going to license for a ground transport, but they're not going to own an ambulance, is that right?
They will have at least one, maybe two ambulances, but when they're out of their area, so for example, the fixed wing transports that happen often in southern Maine, that would be a wet on-demand lease, but they will have 1 to 2 licensed ambulances.
So
in Bangor.
All right, I'll let me articulate this question and keep going.
Go ahead, Tim.
Yeah, Joe, is 3 months, I mean, is that long enough? I assume you have planned it out, but what happens at the end of 3 months? Are you going to be coming back for another waiver?
God willing, no. Sam and I discussed this offline, the appropriate time. Full disclosure, I had originally, we had batted back for 6 months, but in talking with the data folks, Jason, and the folks from the vendors, they feel confident they can get this done in 3 months. And we felt it appropriate to minimize the duration of the waiver as much as we possibly could, and to get the work done sufficiently as we possibly can.
Any other questions before Joe steps out?
So just one comment. I'm not speaking against this waiver at all. But what I do think we as a system should start considering is, what does it look like? What will we need to do to go to a single tool? If ImageTrend doesn't provide the resources that LifeFlight needs, or from what we've been told they do, it's just additional packages that we have to purchase. I think it's something that the board potentially should consider, is adding on those purchases so that we can go to a single system. Because the problem is going forward in the future, the day we add a new element, this is going to be something that they have to do every time that we add a new element. Say when we add questions about exposures and those types of things, that will require a custom build out. Or when we come out with protocols in December and we build out, SAD scales and those types of things. I know those are old build outs. Those will require new custom elements for LifeFlight because they'll be required on our end. So I think it is something that I don't know that we can do it right now, but I think we need to start considering, what does it take for us to say, this is the EPCR that everyone's going to use. And we need to make sure that we provide that at no charge, because if there's a cost that someone has to bear to make it work for them, then I think we're basically monopolizing one documentation system. But if we wholly and fully subsidize the cost, as far as the cost associated with just using the tool, and it works to document the expected document, what we expect them to document, I think we would have the authority to move to that tool as the sole entry point. But I think in the future, I think that's something that we should start considering, is how do we move that pathway? Because right now, an EMS agency, any EMS agency in the state, could decide to go with another vendor, and it takes hours and thousands of dollars to make sure that these are all in alignment. And so if we have the unique capability of having a single point of entry, and this has been huge success in other states, especially Maryland in particular, having this single point of entry that has worked extremely well. So just putting that out there for food for thought. We do intend on asking for a quote in the RFP for all of these build outs for things that would make the image trend project or the image trend program, provide all the same resources as the EMS charts here in this situation. I'm just putting that out there.
Thank you. Any other questions, comments before we start the waiver process formally? Okay. So upon the request of an individual or on the board's own initiative, the board may waive any of the rules by a 2/3 majority vote of those present and voting, and by no less than a majority of the appointed and currently serving members, if it determines that such a waiver would avert a significant injustice while preserving the public safety and integrity of the statutory or regulatory components of the state's EMS system. When determining whether to waive a rule, the board will consider a number of factors, including but not necessarily limited to the following. Whether a person seeking the waiver took reasonable steps to ascertain the rule and comply with it, whether the person seeking the waiver was given inaccurate information by an agent or employee of the state EMS system, whether the person seeking the waiver or any other individual or group would be significantly injured or harmed if the rule were not waived, whether the waiver of the rule in particular case would pose health or safety risk to the public at large, particular individual or community, and whether the waiver of the rule in a particular case would establish a precedent that would unduly hinder the board or office of EMS and the administration of Maine's EMS system. A waiver may only be granted under extraordinary circumstances. This means that the board must find a number of the above factors weighing in favor of the waiver before it is granted. So we will go through each individual question. If you have a comment or at least an opinion, if you could speak up. So the first question, whether the person seeking the waiver took reasonable steps to ascertain the rule and comply with it. Any thoughts or opinions?
Brent, I guess I would ask that of staff if Lifelight made inquiries, appropriate inquiries, and asked the right questions. It sounds like they may have interacted with multiple people. So,
Chair Libby, would you like me to answer that?
Yes, please. Go ahead, Jason.
We've been working with Lifelight since October of 2019, I think, maybe 2020, to transition to 2019, to transition them into the version 3 data set previously. So I would say they have taken the appropriate steps to ascertain the rule and to comply with it.
General thoughts of the board?
I guess the answer would be yes to that question.
I would agree.
You would agree.
Okay. The next question, whether the person seeking the waiver was given inaccurate information by an agent or employee of the state EMS system.
I'd say no.
I would agree with that.
I agree.
Okay. And would this weigh in favor of granting the waiver?
Yes.
Question number 3, whether the person seeking the waiver or any other individual or group would be significantly injured or harmed if the rule were not waived.
I'd say no. Just my opinion.
Agree.
And would this weigh in favor of approving the waiver?
Yes.
Yes.
Okay. Number 4, whether the waiver of the rule in the particular case would pose a health or safety risk to the public at large or a particular individual or community.
No.
That seemed to be the general consensus, a no?
Yes.
I would agree.
And would this weigh in favor of granting the waiver?
Yes.
Yes.
Yep.
Okay. And number 5, whether waiver of the rule in the particular case would establish a precedent that would unduly hinder the board or the Office of EMS in its administration of Maine's EMS system.
I think it does set a precedent. It would allow another service to certainly make the same request.
That's correct. I agree with Tim.
And should that weigh in favor of granting the waiver?
That's the one no.
Any other thoughts on question number 5? Okay. I had neglected to ask on question 1. We said that they did take reasonable steps to ascertain the rule and comply with it. And would that weigh in favor of granting the waiver?
I would say yes on that one.
Okay. So of the 5 questions, we have 5 that are yes and 1 that is no. What is the board's pleasure on granting the waiver to Life Flight for chapters 3, 4, and 5 for submitting required image trend reporting?
Brent, it's Tim. I'll make a motion that we grant Life Flight of Maine a waiver for 3 months to get their EPCR platform in compliance with Maine EMS's requirements. And I would add, I know there's language we need to add to this with regards to the questions that our answers support that decision.
I would say
that. 2 of you are at once.
Amy wants it. Give it to Amy.
Okay. Amy with a second. Any other discussion on the waiver? Okay. I'll do a roll call vote if there's no other discussion. And Tim, I'll make sure that those answers get included in and sent along. Nate?
Yes.
Tim?
Yes.
Carolyn is absent. Brad?
Yes.
Joe Conlon?
Yes.
Heidi?
Yes.
Laura?
Yes.
Amy?
Yes.
Judy?
Yes.
Joe Kellner is abstained. Rich is absent. I will vote in favor. Dr. Martell?
Yes.
Julie is absent. Dennis?
Yes.
Steve?
Yes.
And Scott is absent. The waiver passes. Jason, could you just let Joe back in or let him know that we're all set?
Hello, hello.
Welcome back.
Thanks. All right. Thanks, everybody. I'll take back over from here. Next item on the agenda is a vaccine scheduling tool, which I will ask Sam to present.
Thank you so much, Chairman. So we have been depending on Maine CDC and Maine DHHS to implement a scheduling tool, and we've been told it's coming, it's coming, it's coming. It still hasn't come. We have been told recently that they may be making a switch from the vendor that they originally were going to go with to a new vendor. So we have no idea what the implementation period will look like for that. For many of our services, they're kind of in a pickle right now, trying to schedule hundreds of doses of vaccine, particularly those second doses. And as we expand into potential community vaccinations until a product from Maine CDC becomes available, we're trying to close that gap. Unlike the hospitals and other healthcare entities, EMS typically doesn't schedule 911 calls. Although some people may schedule their calls to 911. We don't schedule 911 calls, and so we have no resources to schedule people unless the entity has like IFT scheduling or some other scheduling tool that they have built in for other services that they offer. That said, what we did is we reached out to FEMA, not MEMA, but FEMA, to get a request for information, and they have authorized to cover the cost of us purchasing a scheduling tool for 100%. So they're going to completely reimburse us for this cost, but because there are restrictions on how much money I can spend, $10,000, I have to ask you for permission before I sign this contract, although I'm getting all the money back. So the contract is for $24,780. And that will give every EMS agency in the state of Maine access to the scheduling tool. So that way, if other agencies want to get into the business, some agencies want to get out of the business, it allows for that flexibility. And it's for 6 months. And so this is a HIPAA compliant tool, and that's where a lot of the cost comes from, is the HIPAA compliance and all the liability protections that are associated with that. But it's for 6 months. I don't think we will use it for the 6 months. I think within 3 months, we will likely have another tool available. However, this is the smallest contract window they would offer. I tried to get it down to 3 months, but they wouldn't do that. So it's 6 months, $24,780. And I'm just looking for authorization to go ahead and make that purchase with the written confirmation from FEMA that we will be reimbursed at 100%.
Sam, who is the vendor, just for the record?
The vendor is Block It Now.
Great. And I assume that, services like this tool, where it's to schedule a reimbursable service after the 6-month period, it would be on them if they wish to continue with the organization. They have that option.
Exactly. There are 2 services in the state already using this tool. And that is Bar Harbor and Peninsula. And we met with them yesterday, and they are extremely pleased with the tool and said that they wouldn't be able to host their clinics without it. So it does work. It works for our purposes. And so we're happy to see that.
Great. Thank you. Any other questions for Sam?
So one quick question. When the CDC is up and coming, will services be required to switch, or will they be able to continue?
So services will be required to switch because the back end labor on our side to send the MEFRS data because when people document in MEFRs, we manually have to send those records. And so when they come out with their solution, we will migrate all EMS agencies to the Maine CDC solution. So there's a universal solution throughout the state. I will tell you that the solution that I saw that I am fairly confident they are going with will make this infinitely easier. Literally, it will be you scan a barcode and that will be all the documentation you'll have to do. Like you won't have to enter in data, you won't have to enter in insurance. That will all be done before a person gets to the site. So it's exciting to know that they have that, but I don't know what their implementation period will be. It may be weeks, it may be months. And so I want to make sure that we have something to cover them until that's available.
Any other questions for Sam? Sam, I think the motion should be to allow you to request the commissioner to sign. Is that how this works? If I remember the process, or will you be signing for it?
Would it be, could you make the motion to allow the Department of Public Safety and/or Maine EMS? And that way it's either of us, because I don't know if the commissioner is going to want me to sign it or who. Sorry.
All right. Yeah, no, absolutely. So I would seek a motion from the board then to allow either the director of Maine EMS or the commissioner to sign a contract with Block It Now for a total of $24,780. Anybody?
Brent, I'll make the motion.
Thanks, Brent. A second?
Second.
Anybody? Second by Dennis. You guys are the motioning and seconding pair today. Any further discussion? Hearing none. Nate?
Yes.
Tim?
Yes.
Brad?
Yes.
Joe Conley?
Yes.
Heidi?
Yes.
Laura?
Yes.
Amy?
Yes.
Judy?
Yes.
I vote yes. Brent?
Yes.
Dr. Martell?
Yes.
Dennis?
Yes.
And Steve?
Yes.
Great. Unanimous of those that are here.
Thank you.
Moving on, the next item on the agenda is regional reports. I see that Rick and Debbie are here. I don't see Joanne, though I could be missing her. Regardless, the regional reports are required as part of the deliverables that exist in the contract. Those were circulated in your packet. What I would like to do for formality reasons is ensure we accept those reports today, but also we won't seek a presentation on those reports from the regions, but give anybody on the board opportunity now to ask any questions that you might have for the regional representatives about the reports that they provided. Are there any questions for the regional reps?
I have one for Rick.
Go ahead, Brian.
Just in reviewing the report and in comparison with the others, seemed like we were under on QI initiatives and having a good chunk of the state. I'm just curious kind of where we're at with that and what we're going to be able to do to improve that, because I would hate to miss out on that deliverable.
Rick, I see you unmuted, but not hearing any audio. If you're able to speak to Brent's question.
So I don't know if Rick's having technical difficulties, but I can speak to some of that, doing some of that QA. So I am obviously doing the QA pieces for him, and we are going through piece by piece and getting them. But the other thing is there actually is more review being done, and that's what gets captured in that. The regional medical directors are reviewing calls, but getting them to use the MEFR system to record using those. I mean, they're sending notes through the MEFR systems, but they're not using the QA piece to do it. So really right now, what I've had to do is if they review something, go back, look at what they reviewed and back enter their data, which is time consuming. So we're working with them, training them to use it. It's just a matter of getting them to remember to use it. So there are more reviews being done than what's listed there. It's just not getting captured it's probably not getting captured as well as you would think. So, but it is there.
Chairman Kellner.
Go ahead, Rick.
Sorry about my technical difficulties. Thanks for the question, and building on what Steve spoke about. Obviously, there's been a lot going on in the first 6 months of the year, but I think as most, or if not all, the board will remember, the contract actually calls for the only time frame for the QI review is within the course of the year, by June 30th, in this case of 2021. And Steve has been working diligently to look at calls and work with the medical directors, and so that has put us a little bit behind between that and COVID of where we'd like to be. But I do want to assure you that by June 30th of 2021, we will meet 100% of the requirements of the contract.
Thanks, Rick. Any other questions from the board for the regions?
Joe, this is Steve again. I will recuse myself from any APMS vote as well.
Okay, I'll separate the votes out to allow that. Any other questions or comments? I did see a couple of people unmute. So, all right, hearing none, I'm going to break these into 3 votes to allow Steve to recuse from the APMS one. I will start with APMS, noting Steve's recusal. I'd seek a motion just simply to accept their report.
I'll make a motion.
Motion by Dennis. Is there a second?
I'll second.
I'll second it.
I got a second by Amy. Any further discussion on the APMS reports? Hearing none. Yes. Nate.
Yes.
Tim.
Yes.
Brad.
Yes.
Joe Conley.
Yes.
Heidi.
Yes.
Laura.
Yes.
Amy.
Yes.
Judy.
Yes.
I vote yes. Brent.
Yes.
Dr. Martell.
Yes.
Dennis.
Yes.
And Scott's not present. It is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 in favor, 1 recusal. Motion carries. Next, let's do Tri-County next. I would seek a motion to accept the Tri-County reports.
So moved.
Second by Tim. Any further discussion? Hearing none. Nate.
Yes.
Tim.
Yes.
Brad.
Yes.
Joe Conley. I see you saying.
Yes, there we go. For some reason, I'm sitting there pushing the button, and so yes.
No worries. Heidi.
Yes.
Laura.
Yes.
Amy.
Yes.
Judy.
Yes.
I vote yes. Brent.
Yes.
Dr. Martell.
Yes.
Dennis.
Yes.
And Steve.
Yes.
Okay. Aroostook reports. I'd seek a motion to accept those reports.
So moved.
Motion by Dennis. Is there a second?
Second.
It's the.
Second by Tim. Any further discussion? Nate.
Yes.
Tim.
Yes.
Brad.
Yes.
Joe Conley.
Yes.
Heidi.
Yes.
Laura.
Yes.
Amy.
Yes.
Judy.
Yes.
I vote yes. Rich. Not here. Brent.
Yes.
Dr. Martell.
Yes.
Dennis.
Yes.
Steve.
Yes.
Until we're getting close to lunchtime. Unanimous of all those that are present. I have to admit, I was thinking a few minutes ago, trying to remember how we used to vote when we were in almost a year. That concludes the scheduled business for today. Next item is items for the next meeting agenda. Anything in particular folks want to see on the next meeting agenda?
Joe,
Sam?
there is one more item on the agenda. I sent out a revised agenda immediately after I sent out the first one regarding out-of-state continuing education courses. Sorry about that.
Yeah, I'm sorry. I must have the wrong version open. Go ahead, Sam, or is that Chris that's going to present that?
So the situation that's presented itself is that in the state of Massachusetts, people use the National Registry system for licensure maintenance, but they're not necessarily nationally registered paramedics. So their state licensure system is managed by National Registry and it's within the same system, but they have clinicians that are not nationally registered clinicians. They only hold a state license. The problem with that is when they come for renewal in the state of Maine, if their continuing education credits are not CAPC credits, then we don't necessarily recognize those credits here in the state of Maine. So what we're looking for is authorization from the board to recognize continuing education courses that are approved by other states, basically creating reciprocity with other states to say, if it's approved by Massachusetts, we will honor that continuing education credit here in the state of Maine.
Does that require any rules revisions, or is it, simply authorization by the board and we're good?
It just says it has to be reviewed, to my knowledge. And so we would say that another state office's review is sufficient for us as well.
So would the motion then be, if it was the flavor of the board, to authorize Maine EMS staff to accept continuing education credits that have been approved by other states?
Yes, sir.
Okay. Any further questions for Tim? For Sam? I'm already getting to the vote in my head.
Oh, just a question. I have a question. Sorry.
Maybe I knew you had a question. There you go. Go ahead.
Does that create an unfair situation for our clinicians in the state of Maine who are held to a higher standard?
As far as continuing education?
So it may be easier to find non-CAPC continuing education online than it is CAPC, or maybe the free versions are non-CAPC. And so now we're saying it's okay if you're a Massachusetts paramedic to license in the state of Maine, but if you're a Maine paramedic, you have to be held to a higher standard.
Well, those courses can still be approved through their training center. They would just have to go get those courses approved. So, we automatically accept CAPC courses, but if they have non-CAPC courses, they can work with the training center to have those approved for acceptance.
As long as there's a pathway for people to be equal.
I believe so, but also other states have very similar requirements to Maine where they have to be approved as well. But some may not, because this is a blanket, if I'm correct, right, Sam, that if the state of Oregon approves continuing education, then you would accept that. Is that correct?
Yeah, so if the state of Oregon approves underwater basket weaving, we would accept underwater basket weaving. Granted, there are nationally, from what I have seen, because in the District of Columbia, we did the same thing. We recognized other states' continuing education. And, from all of the continuing education I saw submitted, there was pretty much a national standard as far as it had been approved by some body, as far as a training center or a state office or a regional office. And so I don't know personally of any states that allow it to be very cavalier and you can just do anything and everything. I don't know of any of those states, but there certainly may be out there that I don't know of. That doesn't say anything, I guess. But that is true, that this would authorize, if another state is super lax, that would open the door there.
Now, obviously you've thought through this, but do you feel that this is the best move for us as a system?
Well, as we've been speaking recently, I know Scott has brought it up multiple times about continuing education opportunities. I really want to make sure that if people are pursuing continuing education, even if it's in another state, they're getting credit for that. So, you know, if you go to New Hampshire or you go to Massachusetts and, you know, say you go to a conference there and that conference is approved by the state of Massachusetts, I don't want you to have to jump through 1,000 hoops to be able to count that towards your renewal if you're not national registry. So to me, it's a risk, absolutely, but it's a calculated risk of saying, I would rather make sure I make more educational opportunities available and make them easier to apply to our system rather than, you know, limiting it a little bit more.
So one more question and then I'll stop, I promise.
No.
So has there been discussions with other states for them to do the same for us? Because there are providers with multiple state licenses that hold various areas that could be actually beneficial to some of our members.
So I haven't had those explicit discussions, but I'm certainly more than happy to bring that up at the New England Council, which they're trying to rejuvenate, especially to have conversations with our regional partners around that specific issue.
Okay.
Any other questions for Sam?
So it's Judy.
Go ahead, Judy.
I just have a question. Maybe should some of those conversations happen before we make a decision on this? I guess this is for Sam.
So the reciprocity to make sure that Massachusetts recognizes Maine CEHs?
Well, it just sounds like, I mean, in terms of Dennis's concerns, that I don't want our people to get diluted. And I certainly appreciate the reciprocity piece. I think that's probably a good way to go. But like you said, you know, underwater basket weaving, I mean, that certainly is not appropriate and probably should not be considered, you know, education towards a renewal of a license. I guess just a question. And maybe if you're comfortable, I'm fine.
And go ahead, Dennis.
I had one more question. So is Massachusetts one of the only states doing this, or is this a problem throughout? Is this for one state that's an issue, or are there many states doing that? I'm just not familiar.
So the issue is if there are states that do state licensure and someone doesn't have a national registry license, we don't renew on someone else's state license. So if you hold a Massachusetts license and you come to me and say, I want to renew because I have this Massachusetts license, we say, congratulations, you have a Massachusetts license. Let me see your CEHs. And so that's the problem, is that we need to have a mechanism where we can recognize those CEHs that they did in Massachusetts to renew here in the state of Maine. And I think, Judy, you make an excellent point. I certainly am more than willing to take this back to my team, to our team, and have it a little bit more formalized. And maybe it's just a regional agreement because we know what we're getting here in the region. And maybe that's what we start with, is a regional acceptance. But I think, you know, because of the questions that have been posed today, maybe the best thing is to table this until the next board meeting, and we can come with a more formal proposal.
I would support that.
Any other questions for Sam? Any motions on the request?
I guess Joe.
Go ahead, Brett.
I think in some ways it's not very much different than our approved CEH list anyway. And I think if they're already doing the training and they already have a Maine license and it's a renewal, then the last time it's been approved by somebody. So I feel relatively comfortable with that. And I don't have a problem or moving it forward.
Okay.
Joe, just Judy. Aren't we talking about out of state people?
Nope.
No.
No, the way I understand it is this would be, if I, as a Maine licensee, receive some continuing education in New Hampshire or Massachusetts, for example, that education could be, in theory, if the office approved it, counted toward my license renewal.
Got it.
Sam, do I have that right?
Yeah, so you're already a Maine licensee.
Okay.
And you do continuing education in another state. We want to be able to recognize that continuing education as long as it was approved in that state where you received the education.
Any other questions or comments or any motions?
Sam, this is Brad.
Brad, go ahead.
Hey, Sam, isn't this common practice in nursing? Doesn't the nursing world do this as well?
Nursing world require continuing education.
I was about to say, I don't think in the state of Maine you need continuing education to be a nurse, but in most states, yes, this is common practice. But they have generally nursing has a more standardized approval mechanism for CEHs, just like the for medicine. Those CEH hours have a very standardized process nationally of how they get approved. And so I think that begs some consideration. I certainly do think that maybe the right move for us today is to table this and let us come back with a formal proposal. I think that this is a very practical solution, but I want to make sure that we have the policy behind, if you do have this, how do you submit it, all of those details ironed out so that we can present those to you as well, so you're comfortable with that.
Joe, it's Tim.
Yep.
I would move to table based on what Sam just said. I think we're creating policy on the fly. And I think having a document that we can read in a process for this, not that it's not a good idea, not that I wouldn't support it, but I don't want to get us in a habit of doing these things off the cuff. I think we need something in front of us that we can read and, have a document that says this is what it's going to be. So I would move to table this request from the office.
Motion by Tim to table. Is there a second?
Judy, and I'll second that.
Second by Judy. Roll call vote. Nate is no longer with us. Tim. Tim.
Yes.
Okay, thanks. Brad.
Yes.
Heidi. Heidi.
Sorry, yes.
No problem. Laura.
Yes.
Amy.
Yes.
Judy.
Yes.
I vote yes. Brent.
Yes.
Dr. Martell.
Yes.
Dennis.
Yes.
And Steve.
Yes.
I will just note that Joe Conley and Nate Allen did step away during that discussion for other obligations. I did ensure we still have a quorum. It's unanimous of those that are present. Tabled till the next meeting. All right. Doing everything twice today. Items for the next meeting. Anything else that we need to add to the agenda for the next meeting?
Just a follow up for Sam to report, with getting the scheduling for the vaccine, that should probably be on there. I'm sure it already is, but just to follow up on that scheduling.
Anything else? Great. And just a reminder, folks do have agenda items they'd like to discuss. Feel free to send that to Brent, Sam, and myself, and we'll be sure we get those on the agenda in advance as well. Thanks everybody for the good work, the good discussion today. Thanks to the staff for all the ongoing work and not the most ideal of circumstances. Next meeting is March 3rd, 9:30 a.m. Look forward to seeing everybody. And at this point, I take a motion to adjourn.
Motion.
Motion by Dennis. Is there a second?
Second.
Second by Judy. Thanks so much, everybody. Have a great day.